Let's begin our lecture, Disorders of the Salivary Gland, and the first section is the Non-Neoplastic Disorders of the Salivary Gland. In this section, we will talk about some common non-neoplastic disorders, which will be chronic recurrent sialadenitis, sialectasis and granulomatous diseases of the salivary gland, and also salivary calculi. So chronic recurrent sialadenitis. Adenitis is for inflammation. Adeno is for the gland. So in this, it's a chronic, long-lasting, over a long period of time. It's a recurrent type of infection of the parotid gland or salivary gland. So it's the chronic recurrent sialadenitis. Parotid gland is due to recurrent bacterial infection. So chronic recurrent sialadenitis is due to mainly bacterial infection of the parotid gland, and it's recurrent. That's why it becomes chronic over a period of time. If it's short duration, it's acute over a shorter period of time. And if it's recurrent and it's over a long period of time, it's known as the chronic. And then remember, we have major salivary glands, and then we have some minor salivary glands. The major salivary glands, we have the parotid gland, then we have submandibular under the mandibular bone, and then sublingual salivary glands. And then there are a lot of minor salivary glands, about 800 to 1000 in number. So we have three major salivary glands, in which parotid is the major largest, and then we have submandibular and sublingual salivary glands. So parotid gland is become recurrent, chronic recurrent sialadenitis as a result of the recurrent bacterial infection. There is since it's a chronic infection and it's a recurrent, so period of acute exacerbation occurs. As with any chronic disease, sometimes there are acute flare-ups of the disease, but it stays there for a longer period of time. So there are acute exacerbations or acute attacks of the sialadenitis. Parotid is enlarged and tender, so the parotid gland here in front of the ear, it becomes large, swollen and tender, painful. Pus expressed from the parotid duct. So as a result of infection, there is pain and tenderness, and there is pussy discharge from the parotid duct. You can see the swollen glands, parotid gland here. The culture of the pus reveals staphylococci or streptococci. So it's a chronic recurrent bacterial infection. The causative organisms are the staphylococci and the streptococci. Cocci are the round-shaped bacteria. So staphylococci and streptococci, they are the causative organisms found on the culture of the discharge or pus from the parotid duct. Diagnosis of chronic recurrent sialadenitis is by sialography, shows normal duct system. So sialography is performed, or graphy is the recording or the tracing. So recording of the parotid gland shows there are normal duct system. Treatment is similar to acute bacterial sialadenitis. Keep good oral hygiene. Avoid drugs which dry oral mucosa, and use sialogs to promote salivation. The salivary glands produce saliva, and this saliva is very important for the lubrication, and even if the tongue is dry without saliva, the tongue cannot even taste. So our taste bud on the tongues require that the food should be mixed with the saliva so we can taste the food. So all these are complications that can occur as a result of the swallowing is affected and the taste is affected with the decreased production of saliva. So we can use the sialogs to promote salivation, different drugs that can promote the secretion of the saliva. And good oral hygiene is important to avoid the infections that can cause chronic recurrent sialadenitis. That's the site of the incision, and then we have the incision retractors, keep the opening open, and then it is closed. So all these are the different steps for the procedure. Sialectasis resemble chronic recurrent sialadenitis. So sialectasis, ectasis or stasis is the blockage or stasis or stoppage of the secretion or blockage of the secretion. Stasis stops. So resembles chronic recurrent sialadenitis. The diagnosis is by sialography. There is dilation of ductal system. So in this sialectasis, there is dilatation of the ductal system, parotid ducts. There is stasis of secretion. Because of the dilatation of the duct, there is stasis of the secretion, and this stasis of the secretion predispose the patient to the different infections, and as a result of this stasis in the secretions, there is chronic recurrent sialadenitis occur. So sialectasis and sialadenitis are very closely related. One condition can lead to the another condition, because if there is a stasis of the secretion and dilatation of the ductal system, then with the stasis of the secretion, they are more prone to infections, and there is sialadenitis. And in this you can see this is sialography, or the picture of the ducts and the parotid gland that is obtained by the sialography. Sialectasis, the condition depends on how worse is the condition, depends on the degree, how bad is the dilatation of the ductal system. It can be punctuate, globular, or cavitary type. So sialectasis is of three types, can be punctuate type, globular type, or cavitary type. Can be congenital involvement of the duct system and stasis of the secretion, or it might be associated with granulomatous or autoimmune disease like the Sjogren's disease or Sjogren syndrome. So all these are the different conditions that can cause sialectasis, which is stasis of the secretion. There is dilatation of the ductal system, can be congenital, is of 2-3 types, punctuate, cavitary, and globular, and can occur as a result of conditions like granulomatous diseases and then autoimmune diseases like the Sjogren syndrome. This is the site of the parotid gland, and you can see there is swelling on the face also, because sialectasis leads to the infection of the ductal system, and then it can spread to the parotid gland and leads to sialadenitis. Granulomatous diseases are like tuberculosis is a granulomatous disease. Tuberculosis is caused by the Mycobacterium tuberculosis or Mycobacterium tuberculin bacillus. It's a non-tender mass necrosis leading to fistula formation. The tuberculosis of the chest, thoracic tuberculosis or lung tuberculosis is the most common type of tuberculosis, but it can spread to the different parts of the body through the bloodstream, and then it can become different parts of the body are involved. So in this there are granulomatous, a granulomatous disease, so there is non-tender mass necrosis leading to fistula formation. If there is necrosis, death of the tissue, then most of the time where there is necrosis, it can lead to the formation of fistula, which is a connection between the two structures and the organ. Treatment of this granulomas as a result of tuberculosis is surgical excision and anti-tuberculin drugs. Another type of granulomatous disease is uveoparotid fever. Uveoparotid fever, it is due to another condition resembles closely to tuberculosis, and it's sarcoidosis of parotid gland, and it is characterized by fever, enlargement of parotid and lacrimal glands, and there is chorioretinitis and cranial nerve palsy. So as a result of sarcoidosis, there is involvement of parotid gland and lacrimal glands which produce the tears, and then there is chorioretinitis and cranial nerve palsies. Actinomycosis. Actinomycosis is a fungal infection. Whenever there is mycosis, is the fungal infection. It's uncommon, not very common. There is acute abscess with sinus formation discharging sulfur-like granules or as swelling in the parotid. The very significant of actinomycosis is the discharge of these sulfur-like granules. And there is surgical drainage, and large doses of penicillin and tetracycline are required. These are the granules that are discharged. So there are three granulomatous diseases: tuberculosis, sarcoidosis, in which there is uveoparotid fever, and then actinomycosis. All these are the conditions in which there is granuloma formation, involvement of the salivary gland, mostly the parotid gland, and then different complications can occur. Actinomycosis is not very common, it's uncommon, and there is secretion of the sulfur granules in the infection, and the treatment is by antibiotics like penicillin or tetracycline. So these are the granulomatous diseases that can cause sialectasis and sialadenitis. Salivary calculi. Calculi is the term for the stones. Here you can see this is the stone present in the parotid duct. We have this is the parotid gland duct. This is the stone. Then we have submandibular gland and sublingual under the tongue. This is the parotid duct. This is the calculi that is removed from the duct. So in ducts of submandibular 90% or parotid gland 10%. Now, as we said, sialadenitis is parotid gland was mainly involved, but when we talk about the calculi or the stones, 90% of the stones are produced in the submandibular gland and only 10% in the parotid gland. It's mainly due to deposition of calcium phosphate that leads to the stone formation. Presenting features of the stone is intermittent swelling and pain. The diagnosis is by X-ray and xylography. X-rays, simple X-rays are a very good test for the finding of the stones if they are present. So both xylography and X-rays can be used for the diagnosis. And the treatment is the removal of the stone from the mouth intraorally or excision of the gland or cut or remove of the gland. So both is treatment can be used, removal of the stone from the mouth intraorally or the excision of the submandibular or parotid gland. So that's the salivary calculi, and the material that is responsible for the formation of these stones is mainly the calcium phosphate deposition. 90% of the cases is submandibular gland and only 10% of the cases is the parotid gland. So this was all about section 1, chronic recurrent sialadenitis, and then we discussed different conditions that can lead to chronic recurrent sialadenitis, including some granulomatous diseases, sialectasis, and the presence of the calculi or stones in the submandibular and parotid gland. Thank you for watching sqadia.com.